To the session on Quinolones from bench to bedside. So the idea of this session is you all know fluoroquinolones are very important drugs for MDR-TB treatment, and there are a number of challenges on diagnosis of resistance, and you know the new issues on using fluoroquinolones for fluoroquinolone-resistant strains with all those issues on low-level resistant strains. So we'll have this very exciting session with start on the epidemiology of fluoroquinolone resistance. Next, we'll have a talk on how do we diagnose fluoroquinolone resistance, and then two talks on the use of fluoroquinolones despite in vitro resistance. First with animal models, and then we'll move to the patient results. So I will present myself. My name is Nicolas Véziris. I work in Paris, France, from National Reference Center. And so I let my co-chair present himself.
Thank you. I'm Zaza Valiani. I'm representing the Georgia National Center for Tuberculosis and Lung Diseases. It's my pleasure to be here and to have such obligation to be co-chair of such important session and be co-chair with such outstanding person in World Medical Society as Dr. Professor Nicolas Véziris. Thank you.
Okay, so we can start with the first speaker, Timothy Sterling, on epidemiology of fluoroquinolone resistance in TB. So Timothy Sterling has a long story of works on fluoroquinolone resistance and mechanisms of resistance, and also very nice works on new regimens for latent TB. Thank you.
Okay, thank you. And I'd like to thank the organizers for the invitation to speak. Dr. Aubrey will follow me, and there's some potential overlap. So we've tried to coordinate things, and I'll mention that as we go along, and she'll provide more detail in some of these important areas. But I've been asked to focus on the epidemiology of quinolone resistance in tuberculosis. This is not really a conflict, it's not at all for this talk, but I am on the Data Safety Monitoring Board for a trial of delamitid by Otsuka. So you're probably aware of this, but just for summary of the role of quinolones in TB treatment and prevention, they're in current guidelines, and as you know, revised guidelines just came out from the American Thoracic Society, CDC, and IDSA earlier this month, and quinolones are recommended for persons who are intolerant of or have resistance to first-line therapy. They're also critical for the treatment of MDR-TB and also recommended for the treatment of extensively drug-resistant TB, and I think that'll probably be discussed in greater detail later in this session. They're under evaluation as first-line therapy for drug-susceptible TB, Moxifloxacin together with isoniazid and rifapentine for 4 months, using pyrazinamide for the first 2 months. That's TB Trials Consortium, Study 31, ACTG 5249. PA824 together with moxifloxacin and pyrazinamide is being evaluated in the STAND trial. And then INH rifampin at a higher dose together with pyrazinamide and moxi is being evaluated in a MAMS trial. And then treatment of latent infection in close contacts of MDR-TB, there are also 2 studies looking at levofloxacin, VQuin and TB-CHAMP. So really an important class of drugs. Unlike other anti-TB drugs, they are widely used to treat other bacterial infections. And I've listed them here. Most importantly are respiratory tract infections where they remain first-line therapy for community-acquired pneumonia. These guidelines are generally in the process of constant update, but these are the most recent guidelines from both the IDSA, ATS, as well as the British Thoracic Society. And in the United States, quinolones are the most commonly prescribed antibiotic class. You can see that there was a 3-fold increase in their use over a 7-year period, and here prescriptions for respiratory tract infections increased 5-fold over an 11-year period. In developing world settings, such as India, there are some data, and I've got 2 slides from the same group. The first pertains to prescribing practices in an inpatient setting, so community-acquired pneumonia, in hospitalized patients at 2 public hospitals. This was a retrospective chart review, 2007 to 2012. There were 261 persons who had pneumonia and then were discharged to home. And the most common antibiotic class were beta-lactams, followed by cephalosporins, and fluoroquinolones were third. And encouragingly, at least for us in this room, was that there was a decrease in the use over that time period from 22% to 6%. Now, in contrast, this group has looked at the use of fluoroquinolones in an outpatient setting. This is from 2007 to 2008. And this table shows the proportion of patient prescriptions according to drug class. And just a couple important points. So they have 3 groups: public sector, private retail pharmacy, and private clinics. And these are the number of persons in each of those groups. Strikingly, about 40% of persons in all groups received antibiotics, so a high proportion with antibiotics. And in red, I've got the fluoroquinolones. You can see that in the public sector, the fluoroquinolones came in second. I mean, it was 9% of persons receiving a prescription. And in the private retail pharmacy, also up high, 11%. And in private clinics, it was almost 14% received a fluoroquinolone. So a high proportion of persons receiving this class of antibiotics. Pinky Gaba looked at this among TB patients in Tennessee. This was several years ago now. And these are persons diagnosed with tuberculosis, and it was using the TennCare pharmacy database. So persons in TennCare had their prescriptions tracked. And you can see that over this 5-year period, the proportion of TB patients who received a quinolone increased from 9% to 41%. And that was statistically significant. Regarding the epidemiology of quinolone-resistant TB, which is what I've been asked to talk about, at least my impression is it requires an accurate assessment of the systematic performance of quinolone resistance testing on all MTB isolates, requires a standard definition of phenotypic resistance and uniform implementation of those laboratory methods, and then also sensitive and specific genotypic tests. And you'll see that we fall short in just about all of these areas. But nonetheless, I will proceed and do my best to try and tell you the current state of affairs. So resistance testing MTB, this comes from the global report which just came out, as well as the paper from Mario Zignol in the New England Journal, also just recently. So in 2014, susceptibility testing, primarily for first-line drugs, was performed in only 12% of all newly diagnosed TB patients. Among those who had previously treated TB, 58% had resistance testing performed. Now, most importantly for this discussion, what about fluoroquinolone susceptibility testing? Well, in 2015, there were 202 countries and territories reporting to WHO. 40 had high TB or MDR burden, and so they're the ones where WHO has focused most closely. 21 of the 40 had surveillance data on resistance to second-line drugs, but only 6 had a national continuous surveillance system for second-line resistance testing among people with MDR. So we really do not have a truly representative grasp on resistance, but that's true of quinolones as well as other drugs. Now, regarding phenotypic testing, Dr. Aubrey is going to get into this in a little greater detail, but obviously it can be done both with solid media or liquid media. With solid media, the agar proportion method is traditionally considered the gold standard, and ofloxacin traditionally is considered the class drug with the critical concentration of 2 micrograms per ml. Liquid media, such as Midget 960, is faster, a bit more sensitive, and perhaps more reproducible, but there is the risk of greater contamination. These are the results of resistance from the WHO from 2008, and just kind of showing where the quinolones fall in relation to first-line drugs. And it's divided into newly diagnosed TB and previously treated. So among those with newly diagnosed TB, you can see that it's generally 10% or less, the proportion with resistance. And that's about true for the fluoroquinolones. There was a range, but about up to 9%. And for those with previously treated TB, it was 28 to 10%, so it's sort of in that range. Now, these are more recent data that came out just within the last couple of weeks from Mario Zignal, yet another paper, and this was actually a whole genome sequencing study, but for fluoroquinolone susceptibility testing midget was used. So 5,015 isolates from 6 sites in 5 countries. Ofloxacin 2 micrograms per ml was the critical concentration. And you can see it varied some, but a newly diagnosed TB, the proportion was highest in Pakistan, 11%, and lowest in South Africa at 1%. Among those who were previously treated, the proportions are higher, 39% in Belarus, and still fairly low in South Africa. Now, another thing that they reported on was proportion with quinolone resistance according to rifampin susceptibility. And so again, looking at the same sites, you can see that among those with rifampin susceptible TB, the proportion with quinolone resistance was fairly low, with the exception of Pakistan. And then those with rifampin resistant TB, there were fairly high rates of fluoroquinolone resistance. So most likely MDR-TB with then associated quinolone resistance. Now regarding genotypic testing, again, Dr. Aubrey will go into greater detail, but just by way of background, we know that quinolones kill TB via lethal double-stranded breaks in DNA. The quinolones bind to DNA gyrase and form a tertiary complex together with gyrase and DNA. And DNA gyrase is composed of 2 subunits, gyrase A and B. The interaction between the quinolones and DNA gyrase occurs really primarily at the quinolone resistance determining region, or QRDR, and that's defined by these codons in gyrase A and gyrase B. It really depends on which numbering system you use, but these are kind of the classic numbering. And missense mutations in the QRDR confer resistance in MTB. Fernando Maruri, a couple years ago, did a systematic review and found that there were 39 mutations at 24 different codons associated with quinolone resistance. And looking at those in gyrase A, 64% of these phenotypically resistant isolates had mutations in the QRDR of gyrase A. The most common mutations in gyrase A are codons 90, 91, and 94. They made up in total 54% of the mutations, or 54% of these phenotypically resistant isolates had mutations at these codons. In gyrase B, mutations can also confer resistance. It's just much less common. Of the 534 resistant isolates in which gyrase B was sequenced, 3% had mutations in the QRDR. This is important because of the rapid molecular diagnostic tests that are available. Again, Dr. Aubrey is going to go into greater detail, but the lower prevalence of these DNA gyrase mutations among resistant isolates suggests that the sensitivity of molecular assays that rely on or utilize these mutations could have decreased sensitivity in some populations. Now, regarding risk factors for quinolone resistance, these are data from Rose DeVazia in a study also from Tennessee. It was among 640 culture-confirmed TB patients over a 5-year period, and 18% had quinolone exposure in the 12 months prior to TB diagnosis. The proportion with resistance overall was relatively low and consistent with what I've shown in other settings, 2.5%. Among those who were exposed, there was a 7% risk. Those who received at least 10 days of a quinolone in that 1 year prior. It was a 13% risk. And those who received at least 10 days of a quinolone, but received it at least 60 days before the TB diagnosis, had the highest risk of resistance at 21%. And in doing a multivariate analysis, after adjusting for age, sex, race, HIV infection, and site of TB disease, really the primary risk factor was quinolone exposure, really greater than 10 days. Now, Uri van der Heijden looked at this in a little greater detail, looking at the generation of quinolone used and whether that was associated with resistance, with the hypothesis that perhaps the older generation quinolones may have a greater, they're not as potent, and maybe there's a greater risk of resistance. So this is a case control study, newly diagnosed TB. There was no MDR-TB. This was mainly quinolone monoresistant. So 25 quinolone-resistant case isolates and 50 susceptible control isolates. The older generation was defined as ciprofloxacin and ofloxacin, and newer generation as levofloxacin, gadifloxacin, or moxifloxacin. And you can see here that the exposure was quite similar, newer and older generation, actually maybe a little bit greater duration of exposure with the older generation drugs, and the median MIC was also similar. And he performed multivariable proportional odds logistic regression models looking for an association with an increased risk of ofloxacin, increased ofloxacin MIC. And this is now the older generation agents, so ciprofloxacin and ofloxacin. After adjusting for age and sex, duration of use of these agents was not significantly associated with MIC. But with the newer generation agents, it was, with an adjusted odds ratio of 1.8, and that was statistically significant. And it could be that these newer agents are not suppressing, but the issue of the mutant prevention concentration and whether this is promoting resistance. So an interesting finding. There's some additional important issues, and these will be addressed in greater detail by subsequent speakers. The alternative mechanisms of resistance, efflux pumps, pentapeptide repeat proteins, and then most recently mutation in the ESX5 secretion system. We know that the MIC varies according to the specific gyrase mutation, with D94G being associated with the highest MIC. In general, 2 mutations is associated with a higher MIC than 1, but there are some notable exceptions. Cross-resistance is common, but it's not 100%. Heteroresistance, also fairly common. In a recent paper from Brandon Eilertson, it was identified in about 40% of quinolone-resistant isolates, and that could affect detection of genotypic resistance. So I'll conclude a couple of slides here. The global prevalence of quinolone resistance in MTB is incompletely understood, but appears to be similar to first-line anti-TB drugs. Phenotypic resistance determined with either liquid or solid media, and there are standard methods, but they're just not fully implemented. Genotypic resistance, at least in the one large survey, showed that most isolates have mutations at codons 90, 91, 94, but a substantial proportion do not. Current rapid molecular diagnostic tests for quinolone resistance detect only DNA gyrase mutations, which could affect sensitivity. Quinolone exposure prior to TB is common, and the timing, duration, and type of exposure prior to TB diagnosis affects the risk of resistance. So with that, I'd just like to thank collaborators and funding organizations. Thank you.
Thank you very much. So the presentation is open for discussion, a few questions. So I have one question. So that's 5 to 10% which is primary resistance among susceptible strains. That's what you showed in few countries.
Right, for the previously untreated TB,
Yeah, so
yes.
That's really impressive. And so, I mean, we do that in my hospital. We do tests for Quinolones for among drug susceptible strains, and we did not see that. We did not see that, but still, if ever at one moment we have a future regimen that is very effective with Quinolones, it may not be feasible in these epidemiological settings.
Well, so this is the question. A question for you. Did you find a higher rate or a lower rate
No,
of
in
resistance?
France we didn't have these high rates, but I mean
Lower rates.
Yeah, if at one moment we have a Moxifloxacin-based regimen and with whichever new drug, these high resistant rates may limit the use of these regimens in these settings.
Well, this is the key question, of course. How high is too high? You know, at what proportion of resistance is it prohibitive to even consider using quinolones for first-line therapy? I guess I was seeing the glasses half full, that potentially you could use it because the resistance rates among previously untreated patients is similar to what's seen with other drugs that are used as first-line therapy. Now, I suppose you could say, well, but quinolones aren't even being used as first-line therapy for TB right now, and you have a resistance rate of 10% or so. Yeah.
Yeah.
Just you mentioned 10 days, sort of the duration of exposure where there was an association with resistance. I just don't know, was there a gradient or was there something seemingly pretty strong about 10 days less is okay?
So the question is about where did the 10-day cutoff come from prior exposure? There was, it was linear. The longer the duration, the greater the risk of resistance. But 10 days is kind of a natural cutoff because a lot of courses for pneumonia are around 10 days.
And what do you make of the fact that exposure 60 days before seemed to be more associated than within the past 2 months?
Right, because going into it, we thought that quinolone exposure closer to TB diagnosis would be associated with a higher risk of resistance, but we found the opposite. And I think it may be that early, longer exposure allows for selecting out the resistant population of organisms, which then become predominant. I don't know for sure, but that's what we're thinking.
Yeah, so hi, Tim. Sorry, I missed part of your talk, but I just wanted to note that in India, from some surveys, it appears that fluoroquinolone resistance is as high as 24%, and in some parts of India, even higher. Like in Mumbai, I believe somewhere closer to 60-70%, which I think Lalit might be able to add to my comment. But I just wanted to note that, and I also want to ask you, what do you think when you have Moxi resistance at 0.5 but not at 2, and do you think at that point that Moxi would be useful to use or not? I don't know if anyone's going to cover that.
Okay, couple things. Sorry you got in a little bit late. I once went to a Bobby McFerrin concert where he repeated the opening symphony in like 30 seconds. It was really good, but I can't do that, sorry. Okay. I did cite 2 studies from India, one inpatient, one outpatient, and actually the inpatient looked pretty good. Outpatient rates were sort of similar to what was seen in this recent WHO survey. I was specifically told to stay away from the cross-resistance issue because that's going to be coming up with Dr. Aubrey and then others, but it's critically important.
Great, thank you.
Okay, one last question.
So, what is this? How does this affect latent TB and people getting treated for other infections if they have a latent infection?
I don't really know. As I said, the quinolones are being evaluated as a regimen for prevention of active TB among close contacts of MDR. You know, we did a decision analysis many years ago, over 20 years ago now, with isoniazid, and because at the time in New York City, rates of resistance were about 25%. And so we wanted to know, did that preclude the use of isoniazid? And it was a decision analysis, and it showed that there actually was some benefit. It was a few days different, better, overall survival among 10,000 people, that sort of thing. And the net take-home was that there was a net benefit even with high rates of resistance. So and we're talking now about quinolones as prevention for MDR, which of course is a mess if you develop active disease. So I think we're still okay. But the VQuin and the TB CHAMP study will show whether it's effective or not, and then also safety tolerability.
Okay, thank you. So we'll move to the next speaker. So Alexandra Aubry on diagnostic performances of existing molecular and phenotypic assays for the diagnosis of Fluoroquinolone-Resistance. So Alexandra has done some pioneering works on the genotype-phenotype correlation in MTB strains. So she'll show us some of this data. I hope so.
Thank you. So I have divided my talk in different parts, answering 4 questions. The first question is, why do we need to perform drug susceptibility testing for fluoroquinolone? As Tim said previously, fluoroquinolone are very efficient drug against MDR-TB, as illustrated by those Kaplan-Meier curves. We know now that the bad prognosis of XDR-TB is mainly due to fluoroquinolone resistance rather than to aminoglycoside resistance. And therefore, WHO estimates that fluoroquinolone drug susceptibility testing is a high priority, especially in countries where drug resistance is highly prevalent. One other reason is that WHO recently advised to use the shorter MDR-TB regimen. Moxifloxacin is part of this regimen, and before introducing this regimen for a patient, we should know if the strain is susceptible to the drug included in this regimen. So which methods can we use to evaluate the fluoroquinolone drug susceptibility testing in TB? There are 2 different methods. Phenotypic methods are mainly culture-based methods, and genotypic methods, which are equally performed directly on specimens and indirectly. The main differences between those methods are the delay to obtain the answer. And as you know, genotypic methods are the only one capable of answering to that question within a few days. Despite this disadvantage, phenotypic drug susceptibility methods remain the reference standard because they are the only one allowing the detection of drug resistance regardless to the mechanism or molecular basis. The only methods approved by the WHO are the automated liquid culture such as MIGIT and the solid culture such as the proportion methods. Other non-commercial methods such as microscopic observation drug susceptibility, nitrate reductase assay, and colorimetric redox indicator are not validated for fluoroquinolone despite some studies has been published. Let's see the principle of these phenotypic methods. If you want to know really more about this, you will have to come on Saturday morning. But you should know that we have a black and white vision of drug susceptibility testing in TB. Since, contrary to what is done for other bacteria, we use a single critical concentration, which is the lowest concentration of drug that inhibits 95% of wild-type strains of M. tuberculosis that have never been exposed to drugs. This concentration was classically 2 milligrams per liter of ofloxacin. But since we now know that among ofloxacin-resistant strains, MIC for later generation fluoroquinolone, Levo, Moxi, and gatifloxacin varied some of them being below the peak serum level of this fluoroquinolone, WHO finally proposed 2 different critical concentration, 0.5 and 2 for Levo and Moxifloxacin. And as you can see in this study performed in 6 different countries, among ofloxacin-resistant strains, many strains are only a low number of strains are highly resistant to later generation fluoroquinolones. So let's see now the genotypic methods. They are mainly based on the detection of mutation in the sole target of fluoroquinolone in TB, which is DNA gyrase encoded by 2 genes, gyrE and GyrB. You can either use a homemade method based on PCR sequence. Perhaps in the future we will all use whole genome sequencing, but before this, we have to face the quality management issue in the lab, and we are quite happy to have commercially available assays. One of those assays, a line probe assay, the MTB-DR-SL test, has been recently approved by the WHO, especially because it has obvious benefits for patients and public health. The strategy now recommended is that for each confirmed rifampin resistance or MDR, this test should be done as initial test to diagnose resistance to fluoroquinolone and also second-line injectable drugs. So which mutations are detected by those tests? The mutations that should be detected are the one we found in clinical M. tuberculosis strain resistant to quinolone. They occurred both in gyrE and GyrB domain called QRDR. Mainly 90% of those mutations occurred in the gyrA subunit, mainly at the 94 position, followed by the 90 position, and 10% of the mutation occurred in the GyrB subunit, mainly at the 538 position. The MTB-DR-SL test has 2 versions. The first versions only detects mutation in the gyrA subunit in this area, whereas the second versions also detects mutation in the GyrB subunits. The performances of this assay are quite good. Of course, we have more data regarding the first version, and as you can see, the pooled sensitivity, either by indirect or direct testing, is around 85%, whereas the specificity is around 98%. Only a small number of studies evaluated the second version. We did one of these studies, and by comparing the second and the first version, we show that the second version have an improved sensitivity without decrease of specificity and PPV and PV values. I should warning you about the mess regarding the GyrB numbering system. 4 different numbering systems are used in the publications. The most widely used is this one. Unfortunately, we now know the right GyrB start codon, and the right one is this one. Unfortunately, those methods have some limits. The phenotypic methods, the WHO didn't recommend any critical concentration for some quinolone and some media. I said previously that among ofloxacin resistance, we can now classify strains as susceptible or with a low level or high level to moxifloxacin or gatifloxacin, but we still don't exactly know if there is a correlation between this classification and patient outcomes. And the two next talk will update the data we have about this point. And finally, we will probably have to define proper susceptible, intermediate, and resistant categorizes as for other bacteria. We also have some lack of data in a correlation between phenotypic and genotypic susceptibility level. We roughly know that the mutation occurring in the gyrA subunit are responsible for higher level of resistance than the one occurring in the GyrB subunits, but we still lack data for some rare mutation. Let's see now the limits of the genotypic methods. I wanted to highlight it 3 limits. The first one concerns the fact that all mutations are not involved in fluoroquinolone resistance. And for example, I said previously that this mutation conferred resistance, but when at the 90 position, the substitution is for a glycine instead of a valine, it didn't confer resistance, but either hypersusceptibility. Unfortunately, the result you obtain with the line probe assay is a resistance result. And this is really an issue when interpreting this test. Those strains with those mutations occur mainly in this region of Africa. Another limit is common to all genotypic methods, and the quality of those methods depends on the prevalence of the fluoroquinolone resistance in the population. Let's admit that the sensitivity is 100% and the specificity 98%, which is nearly perfect. In that case, if the prevalence is 30% among 1,000 patients, you will have 300 positive tests and 20 false positive tests, which result in a nice positive predictive value. But if you perform the test in a population where the prevalence of resistance is lower, and the 2% are quite similar to the level of resistance among all the strains in the population, you see that you have the same number of true positive and false positive tests, so it will be less expensive to flip a coin than to perform an MTB-DR test. So it's really important to use this test in a pre-selected population as advised by the WHO. And last but not the least, of course, we know what is the most frequent, and we are able to detect the most frequent mutation responsible for fluoroquinolone resistance. But we still don't know what happens below this. And below this, we know that in some clinical strains, efflux pump exists, and also a new mechanisms of resistance involving protein belonging to the secretion system of MTB. We also know that probably some pentapeptide repeat proteins similar to QNRs should play a role without any evidence in clinical strains. So we have some work to do regarding this. And the last limit, common to both phenotypic and genotypic tests, is our ability to detect heteroresistance. Heteroresistance is a mixture of fluoroquinolone susceptible and resistant strains, and this phenomenon is as common as in 25 to 38% of the fluoroquinolone clinical strains in the lab. And we perform a study evaluating the performances of both methods to diagnose heteroresistance. We know that when all the population is homogeneous, susceptible, or resistant, the diagnosis is easy. But in the middle time, it's quite difficult, and the genotypic method has low sensitivity, has 33%. So what do we need? Of course, the available methods to diagnose fluoroquinolone resistance have good performances, but we still need to develop improved understanding of the correlation between the phenotype and genotype drug susceptibility testing methods with patients' outcomes. And we also need to determine the limit of detection of genotypic methods for the detection of heteroresistance and in different epidemiological settings. Thank you.
Thank you very much. So the speak is open for discussion.
Just a small technical question. When you talked about phenotypic drug susceptibility testing, you refer to detecting 95% of the resistant? Why 95%?
This 95% came from the initial proportion method, and usually people refer to this method, but we know now that it's not a good threshold because with this threshold you falsely classify 5% of the wild type strains as resistant. It was a principle of precaution used at the beginning of the description of the proportion methods.
Okay, I have a question. Do you believe that with the large implementation of the short regimen, so DST can rely on NTBDR-SL to decide for this regimen, or there should be phenotypic DST for on top of the genotypic test?
Of course, we need both methods because both methods didn't give exactly the same information. Of course, when you see high rates of resistance, as in India, Pakistan, I'm not sure that it's really reasonable to only count on genotypic method to propose this shorter regimen to patients. It really depends on the prevalence of resistance in the population. This is true everywhere.
And to continue on that,
you work with me.
Yeah. The ideas come with listening to you. And do we know if the epidemiology of these mechanisms of resistance are homogeneous around the world? I mean, is it the same balance, the 90-10 between gyrA and GyrB? Is it the same?
It's not the same all over the world, and even in same countries, it's not the same in each part of the countries. So every physician should know the prevalence of resistance among the patient he has to treat. This is crucial.
So, I think it's on. Okay, so if you have to know the prevalence of fluoroquinolone, we are just starting to do some of those surveys. So countries won't know the prevalence. So how will they use that test? And that's the catch-22 question. So if we only did, the previous surveys only looked at first line for drugs, and then now we're starting to move into looking at in the new surveys.
You know, it's that question is right for fluoroquinolone, but it's also the same question for delamanid or bedaquiline. What are we doing? We are using them without performing drug susceptibility, phenotypic drug susceptibility testing at the same time. So we have to do our best, but of course it would be better if the more information we have, the more is it, the better is it.
So I have, as a researcher, I have a question as why to use a critical concentration and not just the MIC?
It's not exactly the same kind of work in the lab to perform MICs and those phenotypic tests. It's more complicated to perform MICs, so it depends how many strains and how many people in the lab you have to perform this. Of course, one method, the TB exists, which can be pooled with the midget technique, could give this kind of information, and probably we should have a look of this in the future, but it's not a technique that would be easy to implement in all the laboratories.
You were talking about testing at a single time point, but this data you presented of the mixed infections, or the mixed, not infections, but the mixed genotypes as over-treatment was over time in South Africa. So if we can think, if you are not sure at time 0, maybe you can go ahead, but then follow up with monitoring. And I mean, this is probably something we have to think about with TB, because the treatment is long and complicated, and we do need to be flexible and individualize therapy.
Yes. You mean for the same patient?
Or follow up, yeah.
Yes.
Multiply sampling different patients. And then you will increase your predictive power, presumably.
But of course, we have to choose every, if we perform a new DST every week, every 2 weeks, every month.
Okay, last question.
You had a slide that 66% of resistant strains have gyrA mutation.
This is a mean rate.
Okay,
Yes.
mean.
Yes.
And the earlier speaker was 54%, for example. So I'm just wondering how on earth...
The 54 was mutation occurring in the gyrA subunit at 2 specific positions, the main frequent one.
That math doesn't make sense to me as to how the Hain test or any genotypic method could achieve pooled 87% plus sensitivity.
Because the 66% is a mean when you have a look on all the data published in the literature. If you for example, in France, less than 5% of the strains resistant to quinolone have no mutation in DNA gyrase. And there is a lot of heterogeneity regarding the percentage of strain having mutation in gyrase among fluoroquinolone-resistant strain. And usually, in most of the study have mutation higher than 85%. But some of them have reported has a very low proportion of strain resistant to quinolone and having DNA gyrase mutation. I'm not always sure that all those strains are really resistant to quinolone, but those data are published.
Okay, thank you.
Thank you, Dr. Aubrey. This presentation makes us sure that pessimists are well-informed optimists. So the next presentation is very important basic research. Can fluoroquinolones be used for the treatment of MDR-TB? Nicolas Veziris, Professor Veziris will present. Please.
Thank you very much. So I do not have any conflict of interest. So the two first presenters, I think, show that pretty well. There is variability in the levels of resistance to fluoroquinolones. And so we've done this works with Alexandra since now about 10 years, trying to link the genotype with the phenotype. And we've been seeing that we had these various levels of drug resistance. And for example, I mean, whoops, sorry. Here, you have different positions, and you have the MICs. Just look at the MOXI MICs, which are in red. All these are H37RV mutants. They have all the same father or mother, whatever. And so they're all from the same lineage. And you see there's various levels of drug resistance. So obviously, there are different phenotypes. And of course, when we saw that, we also saw that for a number of these resistant mutants, the MIC, although higher than the wild-type strain, is under the peak serum level of MOXI. Usually the peak serum level of Moxifloxacin is around 3 milligrams per liter. And so, of course, the question that arose from that is, maybe we could still use MOXI against these drug-resistant mutants. And so what we do in the lab, and what I do is mouse modeling to answer the questions. So that's what I will show you today, the results of this mouse data, and then we'll have another speaker on the human data. So what we did, and that was the very first work we had on this, is we used these isogenic mutants of H37RV, and we selected 3 of these. 2 have mutations in gyrA and 1 in GyrB. They're all officially resistant to fluoroquinolones. You see the MIC is more than 2 milligrams per liter of floxacin. And you have this increasing MIC of moxifloxacin, and the peak serum level of MOXI in human is just here. So what we did is that we infected mice with these mutants and with the parental strain H37RV, and we treated these mice with moxifloxacin. So we used different dosings of moxifloxacin. I will not enter in the details. These different dosings were used so that the PK in mouse is equivalent to the one in human. And when you give 400 milligrams per day of MOXI in human, of course, the AUC changes from one patient to the other. And with these dosings, you have the upper and the lower limit of this AUC. So you have the variability you have in human. And so we treated the mice for 1 month, and then we sacrificed them at the end of the month to do the CFUs. So I will show you the results for each of these mutants. And so it will be done this way. So this is the parent susceptible strain. So MOXI MIC 0.25 milligrams per liter. Here on the left, you have the survival rate. So that's after 1 month of treatment. So all the untreated mice died, almost all, and all the treated mice survived. So that's what you expect when you treat a susceptible strain. And when you look at the decrease of the CFU counts after 1 month, you have a 2 to 3 log 10 CFU decrease. So that was confirmatory. MOXI prevents mortality in mice, and has bactericidal activity, decreases CFU counts. So let's move now to the first mutant that has an MIC, which is just one dilution over. It's the GyrB mutant, 0.5 milligrams per liter MIC. So all the controls died, and more or less all the treated mice survived. So Moxi prevents mortality against this officially Fluoroquinolone-resistant mutant. And when we look at the CFU counts, what we see is that if we want to have a CFU count equivalent to the 2 to 3 logs reduction you have for the susceptible strain, you can have it, but you only have it in the mice with the higher AUC. So if you imagine your PK variability you have in humans, you will probably also have this, this variability here. So prevents mortality and is bactericidal when used at high dosing. So let's move to the next mutant. This gyrA A90V, very frequent mutant. MIC, 2 milligrams per liter, so just below the peak serum level of Moxi. And so all the untreated mice died. And when you look at the survival rate of the treated mice, so you have you know, a ranging of mortality. So they survived, and here they're in the middle. So obviously, you do prevent mortality, but only at high dosing. So the one that for which there was prevention of mortality, it was this dosing here. But when we look at the CFU counts, there was no decrease at all of CFU counts, and it was increase of CFU counts. And then we move to the last mutant. This is the 4 milligrams per liter. Against this mutant, we did not expect activity. It was some kind of negative control, the MIC being higher than the peak serum level. And indeed, compared to there was less mortality in this experiment, but still, there was no difference between treated and untreated mice, and there was CFU increase in all the mice. So that's confirmatory, but we did not prevent mortality, and there was no bactericidal activity. So that was the first conclusion. In a murine model, Moxifloxacin retains partial activity against DNA gyrase mutants, and only against those who have an Moxi MIC that is at most 2 milligrams per liter. So we submitted this paper for publication, and one of the many reviewers told us, yeah, that's really fantastic, but we never treat patients with only one drug. We treat them with drug combinations, okay? And does all this story still stand true in a drug combination? Because, and man, the question is right. I mean, if you add a lot of drugs, maybe there's differences there. They will be completely erased by the other drugs. So, okay, let's start with that. Yeah, just look at the total number of mice here. And that's a 9-month experiment to answer the reviewer. So we used the same mutants. And we did a typical MDR-TB regimen. MICase in 2 months, Moxi, ethionamide, and pyrazinamide for 6 months. And we looked at the relapses 3 months after the end of treatment. So Aurélie Fillon did that work. And voilà, just look at the number of injections. So I will show you directly the CFUs. So the blue are here the RV, and then you have the 3 strains with the increasing MICs. So what you see is that at the end of the 6 months, they were almost all culture negative, and then they were left without treatment, you know, for assessing the relapse rate. So no relapse with the susceptible strain, and then we had this increasing relapse here that was really parallel with the MIC. So the higher the MIC, the higher the relapse rate. And so the sterilizing activity was correlated with the resistance level, or the relapse rate was correlated with the resistance level. You can turn it how you want. So that was our second conclusion. Obviously, the impact of fluoroquinolone resistance is not on-off. You saw that depending on the MIC level, the activity of the regimen changes. In a murine model, the level of moxifloxacin resistance is correlated with the activity of moxifloxacin in drug combination. But still, it supports the use in case of low-level resistance, less than 2 milligrams per liter. And I think that would be shown after, but of course, this is linked to the genotype. So that was for Moxi, and then we come to the last study I wanted to share with you. So what about other fluoroquinolones? So this is an unpublished yet work, and we looked at levofloxacin. So against drug-susceptible TB, we use Moxi 400 milligrams per day. Against quinolone-resistant strains, of course, we thought about using higher dosings in patients, and I must say that we've done that for some patients. But we also have Levo, and we have data showing that this, especially this one, the 1,000 milligrams per day levofloxacin, is very active in TB patients. And when we started building this experiment, we had also bedaquiline arriving in France with all the QT issues. And Moxi is clearly more at risk of torsade de pointe than levofloxacin. And so, of course, we would prefer using against these XDR strains levofloxacin than moxifloxacin in combination with bedaquiline for safety issues. But of course, the question was, do we still have the same benefit? So that's what we tried to model in mice. So just to show you here the MICs, it's the same figure, the same table. Levo is in yellow here, and you see here the usual peak serum level around 10 milligrams per liter. And you see that, okay, based on MICs, you imagine that Levo will be active, and even, I must say, maybe more active than moxifloxacin when you look at the peak serum level and the MICs. So when we look in more details, so here on the left you have MICs, and on the right you have PK of the drugs. And so be careful, these are still isogenic mutants we selected in the lab, but they are not the same ones. So you still have RV here, the parental strain. You still have this one, the A90V. And we added these two GyrB mutants. And we added these two mutants because we really wanted to see in details how low-level resistance has an impact on the activity of the drugs. And I just underline that if you believe and if you use the definitions of WHO, these strains are called phenotypically susceptible to fluoroquinolones. Okay, they have mutants, but they are officially susceptible. Okay. So if you look at the MICs, obviously they are lower for Moxi than for levofloxacin, okay, about 1 dilution lower. If you look at the PK here at this dosing, so 750 or 1,000 and 400 and 800, obviously the AUC is much higher with levofloxacin. So on the one hand, you have more favorable MICs with Moxi, and on the other, you have more favorable AUC for levofloxacin. So when you mix all that, who is the winner? Little suspense. So here are the results. So here on the left, you have levofloxacin, and on the right, moxifloxacin. So these are the dosings that have been used. So mice have been treated every 6 hours. And I will show here the photo of the guy who did that. And so that we have AUCs corresponding to these dosings in human without having a high Cmax. So that's why we had to repeat dosing in mice. And what you see here is the CFU decrease or increase for RV and for the two GyrB mutants, which are officially susceptible, and the gyrA A90V mutant. So what you see is that when you compare to RV, you have decreased activity of fluoroquinolones, even for these officially susceptible mutants. Okay, so which makes sense. I mean, the MIC is not normal; it's elevated, but there is decreased activity, and you have this decreased activity even at high dosing of Moxi or at high dosing of levofloxacin. So the second result is that, of course, when you compare Levo on the left and Moxi on the right, and here this is when you have a CFU decrease, obviously it's much, in this model, Moxifloxacin is much more active than Levofloxacin. So that was our question, and the answer is it's much more active. So we were a little bit surprised by these results. Actually, I was hoping and expecting that we would have maybe even better activity for Levofloxacin. So I showed you that there is an MIC side and an AUC side. So what we did is that we plotted these CFU decreases in relation with the AUC on MHC ratio, which is predictive of activity for fluoroquinolones. And so here you have increasing AUC on MHC ratio, and you have the CFU decrease in red for Moxi and in green for Levofloxacin. And what you see, you could guess that from the previous slide, but it's more nice here with this curve, is that for the same AUC on MIC ratio, Moxifloxacin is more active than Levofloxacin. So although there are advantages, but for the same ratio, Moxi is always more active in this model. So conclusion 3 of this experiment, Moxifloxacin is more active than Levofloxacin against Fluoroquinolone-resistant strains in a murine model. Based on this data, that does not support the use of Levofloxacin against Fluoroquinolone-resistant mutants. And so that's my general conclusion. Fluoroquinolone resistance is obviously not on-off, and these mouse data show you that there is really a spectrum of decrease of activity. Strains with less than 2 milligrams per liter MIC can still be treated by Moxifloxacin, but with decreased activity. I mean, we probably need not to forget that. Although we've seen that with the human data, maybe we don't see that clearly when we have cohort of patients, but there's clearly a decreased activity, and that makes sense. And, well, based on our data, Levofloxacin is less active than Moxifloxacin. Thank you.
Thank you, dear professor, for your excellent presentation of which is the very important point of view for all of us, and not only for all of us. And please, the questions, I do hope that you will have a lot of questions, but we are limited on time, and please, 3 or 4 questions maybe. Please. Please provide with microphone.
Go back to your last slide. Thank you. One more back. Okay, I just want to point out that the difference between 1,000 milligrams of Levo and 400 of Moxi is not much. So that I agree with your conclusion, but I would say that it would be much wiser to use the Moxifloxacin at the higher dose. And I think that's an important conclusion.
Yes. Yes, I completely agree with you. The only small limit of that is that when I leave the mice and I go to the patients, in France, when we combined bedaquiline and Moxi, we saw a significant QT interval prolongation in these 800 milligrams patients. So that's the only limit. But I completely agree with you on the efficacy.
Please.
The AUC of Levofloxacin at 1 gram a day is considerably higher than Moxifloxacin at 400 milligrams a day. What happens if you normalize your data for relative AUCs?
For relative, I'm not sure I understand the question, but this is we normalize that on the AUC on MHC ratio, which is predictive of activity in Quinolones, and what we see is more activity of Moxi versus Levo.
And as a second question, is protein binding different for the mouse versus human?
Yeah, so that's maybe one of the limits. Actually, this difference between Levo and Moxi has been shown in other previous mouse experiments. even against susceptible strains, which I also show here. So that's probably one of the limits on the relevance of these experiments to humans. So I'm not completely sure about that. But still, I mean, since we had this data, I must say that when we had to make our choices for patients, we tried more to push on the MOXIE side, unless, of course, there was big issues with toxicity.
Thank you. One more question, please.
Well, is there any role for Moxie 400 in that case, or 600?
600, I don't know. But 400 probably. Then it probably depends, and that's, as you see, I mean, that makes a lot of difference if you are this strain here, which is really a frequent mutant, or if you are one of these mutants, and that makes a big difference.
So we really need to get down to the mutation analysis at that
but
point.
you probably have more data in the next speak on that.
Yeah, and then one other quick question, and that is when the data that you show is very interesting as there's no pediatric formulation for Moxifloxacin. Just to note that if you're showing that Moxie is that much more effective than Levofloxacin, we really need to consider that we advocate for some sort of a pediatric formulation for Moxie.
Okay. Oh yeah, I forgot. So these guys give money, and those ones gave a lot of their brain, and those guys treated the mice, so especially Thomas, every 6 hours. Huh? So thank you, Thomas.
Thank you. Thank you. Now the next presentation. By the way, it's the same presentation, but lessons from human studies. So can fluoroquinolones be used for the treatment of MDR-TB? And Lynn Rigouts will be present. She will present instead of Armand van Deun. She's from Belgium. Please.
Okay, thank you. I try to be complementary to what has been said before. First of all, I want to say that I'm here presenting on behalf of Armand, who couldn't make it, unfortunately, but by no way I can replace him. So if we have questions, I hope somebody from the audience can assist me as well. Okay, so coming shortly back to what has been said about cross-resistance amongst the fluoroquinolones. This is from work that we have previously published this year, and it nicely shows that indeed there is a linear correlation between the MICs of, in this case, ofloxacin versus moxifloxacin, yet moxifloxacin is more powerful, has lower MICs. And the same is true for the comparison between ofloxacin and gatifloxacin. But MICs are about twofold lower for gatifloxacin and moxifloxacin. And in our studies, we see that gatifloxacin is a little bit more powerful than moxifloxacin in vitro, yeah? But not significantly different. So do we have data from humans whether fluoroquinolones can still be used if you have any fluoroquinolone resistance? So there's no randomized clinical trials that have been done to really look at this specific question, but there are some studies, and one of them is from Korea in a retrospective study done on an MDR-TB cohort, and it had 70 ofloxacin-resistant patients, and 48 of them were also found resistant to moxifloxacin, so they are supposed to have high-level fluoroquinolone resistance. And furthermore, we had 26 of these were XDR, again, of which 19 were moxifloxacin resistant. the patients, they did receive individualized regimens with a later generation of fluoroquinolones. So most of them had Moxifloxacin, but some also Gatifloxacin or Levofloxacin. So it was really individualized treatment. But and it was not randomized, but when they did the analysis, the groups were comparable. Yeah, and 91% of them were susceptible versus 71 of the Moxifloxacin treated were Moxifloxacin resistant. So what was the outcome of this study? If you look at the failures, so 10% of the Moxifloxacin susceptible patients failed, whereas 44% of the Moxifloxacin resistant ones failed with this treatment with the Moxifloxacin. Yeah? The success rate was, in a similar way, a significant difference between those that had Moxifloxacin susceptible strains and Moxifloxacin resistant strains. So there is clearly a difference in the success rate whether you have susceptible or resistant strains. But all of them were ofloxacin resistant. Yes, you have to remember that. So they were ofloxacin resistant, but yet part of them that were susceptible to moxifloxacin had good treatment outcome. There is another study done, and the reference is not on here, but it is a study done by Jacobson and the team of Megan Murray. And it was a meta-analysis of MDR-TB patients, and it included 13 observational studies. Again, no randomized trial or so whatsoever. And it had 560 patients, of which 44% cured and 21% died. And those that were treated with a more later generation fluoroquinolones, like moxifloxacin, had a more favorable outcome. And in the complete cohort, the ones with the later generation treated, they had 40% increase in success. That was the overall finding of this meta-analysis. Now, the data that we are more familiar with is the famous Bangladesh cohort, and it has been published by Dr. Ong. And this was an observational study, and this population in Bangladesh typically is a population with low HIV infection, and most of the patients present with an advanced disease. You all are familiar with the famous regimen, short month, 9-month regimen, that was published by Armand. And to highlight, we have been talking much about moxifloxacin, but this treatment used gatifloxacin. Gatifloxacin was the poor drug. It is a very powerful drug, and I think the data from the mice that have been shown on moxifloxacin indeed show that moxifloxacin is very powerful, but gatifloxacin in vitro is at least as powerful than moxifloxacin. So, and gatifloxacin, despite of publications about problems with the, hypoglycemia or hypoglycemia, I don't remember. There is an issue anyway, but in this study, there was less problems with this than was previously assumed. So the patients were giving high dose. That's very important to know that it was high dose gatifloxacin treatment. And why was that? To overcome more resistance during the treatment. If you have already low-level resistance and you give high dose, you probably overcome this and you avoid that there's more resistance generated. So it is important to know that it was standardized treatment, and so all patients did receive drug susceptibility testing on the isolates, but the treatment regimen was not adapted accordingly. Yeah, and the intensive phase normally is 4 months, but if there was no conversion, then the intensive phase was prolonged. And about 50% of the patients in this cohort indeed had a prolongation of the initial phase. And the follow-up was done for 24 months post-treatment in this cohort. So the treatment outcome analysis from these patients, So that was strict definitions that were used. Go quickly over. Cure meant that there were at least 5 negative cultures in the last 12 months. So it was a 9-month regimen, but you remember that many of them had prolongation of the initial phase. That's why it says 12 months. So completion, and then there was failure if there was at least 1 positive culture from the 5th month onwards, and relapse if there was at least 1 positive culture in the, after successful treatment. Oops, sorry. And reinfection and lab error were sorted out by doing fingerprinting analysis. So overall, it was a very successful treatment with 85% treatment success compared to only 1.4% treatment failure. Those that were not successful in treatment was mostly due to defaulting, yes, but overall very good treatment success. If you look at initial drug resistance, whether it has an impact on the treatment outcome, and here the outcome success are not success, but the success is a sum of all adverse events. So it is both failure, but also relapse and death, and everything is included in here. You can see that for the fluoroquinolones, those that are susceptible, 13% had a non-successful treatment outcome. If you look at the low-level resistance, it was 9.1, but the high-level resistance, so the high MICs, it was really not a good outcome. It was 1 in 2 that failed treatment in some way. If you look at the kanamycin resistance, aminoglycoside resistance in Bangladesh overall is very low prevalence of that. There were actually only 2 cases in this cohort, and 1 of them failed treatment, and 1 was successful, and this was one was an MDR-TB actually. So if you visualize this treatment outcome and you stratify according to the fluoroquinolone resistance, you can see that those having low-level resistance to fluoroquinolones are being susceptible, had overall good treatment outcome, and the high-level resistance mostly failed the standardized high Moxifloxacin treatment. Was this impacted by other factors, patient-based or bacillus-based, let's say? Patient-based, we know, of course, there's a lot of confounding factors that can play a role, but remember, this is mostly HIV-negative patients. So that was not an influencing factor. But regarding to the resistance profiles of the bacilli, pyrazinamide also played an important role. It was borderline significant in a logistic regression analysis, but a high-level resistance defined as an MIC of gatifloxacin above 1 microgram per milliliter, which is more or less close to the 2 microgram per milliliter that we have seen for Moxifloxacin. And so I will come back to that later. And then there is acquired XDR-TB from, there was 1 case of acquired fluoroquinolone resistance. And 1 in 2 XDRs succeeded. So to come back to the MICs, we did more intensive analysis on this, and here you can see the MICs for gatifloxacin versus the cure, and you can clearly see if you go above 2 microgram per milliliter, you see a significant drop in the cure of the patients, and which is similar to the mice findings. If we come to the mutations in the gyrase AB, here you can see the mutations that we came across in this cohort, and you can see that the wild types had a good, very few of them failed. For those having the 90-valin mutation, it was some of them had good outcomes, some had less good outcome, but mostly the 94 glycine had very poor outcome. Yeah, and overall, if you combine all the mutations in gyrase A, in gyrase A at position 94, apart from 94 alanine, you have a very bad outcome prediction. if you take the remaining gyrase A mutations, you still have a fairly well treatment outcome. So indeed, there is a difference between the mutations. It has been shown in the mice studies as well, and it can be detected by using the line probe assays. It was one of the questions, can we predict from the line probe assays? To some extent, yes, you can exclude those that definitely should not have high dose next generation treatment. Okay, I have to acknowledge the team in Antwerp who did a lot of work, especially also Armand van Deun and the team in Bangladesh from the Damien Foundation. Thank you.
Please, questions. We have few minutes, please.
And thank you very much for this last-minute change. Thank you. So, yeah, well, I have a question, of course. So finally, I mean, we put out the 94 mutants except the 94A, and the 90V, I mean, it's more or less in line with the mouse data. It's not so fantastic, eh? So there's room mainly for the others. Huh? Even the 90V, the benefit is so and so.
Yes, the 90V, if you look at MIC, in your study, the MIC was very tight for all of the mutations, but in many of the published studies, the MIC distribution for each of the mutations is not very strict. It's more, they overlap kind of. So the 90V, yeah, I think maybe you can continue the use, but not count on it as being fully susceptible, but it depends on what alternative you have available, I would say, yeah.
I guess just a general comment of anyone is that now with the new WHO guideline to use, I think, some second-line susceptibility testing to triage individuals for short course regimens in countries that are going to do that. For a lot of countries, that means rolling out Hain testing. And based on all of the complexity that we've seen, A, with the Hain testing, B, in a lot of countries that have very low prevalence of quinolone resistance, I mean, not Pakistan or whatever, but some of the other countries. And then the fact that a lot of these mutations are not going to give you high-level resistance and they're still decent outcomes. To me, it seems like a lot of work to roll out second-line quinolone susceptibility testing to everywhere to enable short-course regimens if you don't have high levels of resistance epidemiologically, and you're going to get a lot of misinformation potentially from the Hain for these 90 mutations and these other mutations. So it's just a comment.
Yeah, I think it comes back to your question from which prevalence in the population you have to start testing, and yeah.
Okay, so if that's all for the questions, thank you very much, and
thank you.